can have the next presenter, Dr. Arvind Kumar Morya. Because of another presentation, another hall, so he had to be there. So he'll be presenting on the OMNIFLO. Over to Dr. Morya, please.
Thank you. Greetings. I am presenting a new innovation, OMNIFLO, a novel, small and effective drainage device for complicated open-angle glaucomas. Routine trabeculectomy with or without implants are associated with many complications like shallow anterior chamber, choroidal detachment, phlebitis, long surgical time, etc. OMNIFLO is a sutureless, short shunt to drain aqueous from anterior chamber to the retrobulbar space behind the equator, which is virtually free from fibrosis even without mitomycin C and can drain up to 500 microliter per minute. This is how this 50 mm length with 0.3 into 0.7 mm drainage device looks. It works on the principle of Bernoulli's and Hagen-Poiseuille, means an increase in speed of fluid with a decrease in pressure or fluid's potential energy even against gravity twists and turns. After putting a L-shaped cut in the conjunctiva and after little blunt dissection, vectis insertion to reach retrobulbar space. Up to 40 mm of wire vectis can be inserted with ease and it creates a tract. After this, at 45 degrees and 5 to 7 mm away from the limbus, a scleral tunnel is made with 23 gauge angled MVR plate. This tunnel is properly lubricated with 2% HPMC. The beveled end of OMNIFLO is now inserted and passed through the scleral tunnel. 3/4 length of the OMNIFLO tube is pulled out and the walled distal end of the tube is inserted into the retrobulbar space, which goes into the retrobulbar space quite smoothly. Now, a second scleral tunnel is made, which is radial or perpendicular to the limbus up to 2 to 2.5 mm from behind the limbus, which is then gently entered into the anterior chamber, bisecting the angle of anterior chamber and the iris. Now, the beveled end of the OMNIFLO tube is inserted into the anterior chamber via this tunnel. Care must be taken that only the beveled 1.5 to 2 mm end goes inside. Conjunctival flap can be glued or sutured. This is a case of double OMNIFLO. IOP was around 100 mm of HG in a one-eyed patient who had undergone multiple RD surgeries with repeated silicone oil injections with multiple failed trabeculectomy. After surgery, IOP came down to 19. These were the results in the clinical study with success rate of over 95% in 29 eyes. IOP came down from 30 to 70 mm of HG to 10 to 15 mm of HG immediately after the surgery. 24 patients maintained this level of IOP without any medications till a year. 4 patients required 1 anti-glaucoma medication. There was no loss of vision and lines in any patient. So, in conclusion, OMNIFLO will revolutionize the management of all types of primary or secondary intractable open-angle glaucoma, neovascular rubeotic glaucoma, silicone oil-induced angle recession, posterior embryotoxin, and glaucoma in Sturge-Weber syndrome by keeping IOP between 10 and teens 24/7 and free from complications of trabeculectomy. My acknowledgements. Thank you.
Thank you.
Yeah, good thought, Dr. Morya. So just a few questions. One is, most of these newer ones come with the, whichever the ones which we use come with the plate. Even the RD or the Ahmed valve come with a plate, though they are more anterior. The reason was that less scarring and more spread. In yours, there is no valve.
Yeah,
so
there is
how
no
many
valve, sir.
how many shallowings of the anterior
None, sir.
chamber?
None, sir.
Corneal touch,
No, sir.
Hypotony.
None. Because we are using it in
Hypotony.
open-angle glaucoma. No hypotony. No.
extrusions.
No, sir, not till now. We have done 173 cases at 3 centers, and there is no complication. It's a very small, I think I can show it to you. It's very small.
How many times did the tube get blocked?
It haven't blocked, sir. Not a single case
hasn't.
till now. No. There is a Teflon valve, if you see, at the end.
Okay.
So it opens up and it closes up depending on the how much the anterior chamber has the pressure. If the pressure is very high, so there will be it will open up fully, 175 to 225 microns, right? And if the IOP is lesser, so there will be only trickling of the aqueous, right, sir? And if the IOP is between teen and teens, we have adjusted the Teflon valve, so then it will there won't be any drainage. So this is the advantage, that it doesn't require that bulky, like the Ahmed valve plate, nothing, just into the retrobulbar space, and retrobulbar space is free of myofibroblasts.
But it would still fibrose.
No, we haven't observed any. There are 3 studies in glaucoma, so they have done. I put the reference also in my that it is free of myofibroblasts.
Oh.
That's why we are able to exploit that space. And the aqueous drainage is only 2.8 microliter per minute, but this tube can drain up to 500 microliter per minute, up to 170 times higher.
And how long is the follow-up been, Dr. Arvind?
It's 3 years now, sir. It's 3 years now. And it's commercially available also now, 7.5 thousand.
7,500.
Yeah.
What is the need to have that L shape? Why should there be a kink in the tube? There is a horizontal passage and then there is a vertical passage into
To
the
able to keep it fixed, ma'am. And the Bernoulli's principle, I said as this movie, na? So this kinetic energy, the potential energy of fluid, even without gravity, twist and turn, they will have some kinetic force. So we are utilizing.
that turn I'm asking you, instead of having one horizontal and one vertical scleral support,
Yeah.
you can have 2 vertical scleral supports. So that
Yeah,
need to-
the surgeons are using different technology.
bulbar space. There's no need to have that L-shaped kink is what I'm trying to ask.
Yeah.
Because you have a purpose for it.
Yeah. Means to fixate it, and so many surgeons, they are using different technique. But it's not kinking, it's just a turn. So it doesn't hamper any fluid or the aqueous. Never.